has been working from home for months in San Antonio, and Phil's in Connecticut, and Judy Lely is next door. We see her. Good. Yeah, we see her. We have spaced drinks on Sunday night. And
there you go.
Outside, so that's nice.
It's good.
Yeah.
Gerard, I'm glad to see you too.
She's a help. She gets me.
Ooh, got a few more photos.
Yes, well, Mike, I seem to have a scatter.
I don't have. Can you? Who about the call-ins, please?
Oh.
One is me, Dr. Okay, and who else? The other one?
There we go. Muted now. All right. So what time do we have? Anyone? We can wait another minute. We still have some folks coming in. There we go.
So we'll give just a couple more minutes, Melissa, and then I'll wait for Gerard to return.
Oh yeah, of course.
And then we'll go ahead and get started.
Perfect. Oh, I think we might have lost someone, but I'm sure we're starting back.
It's okay.
You never know with bad weather and people get kicked off and then come back on.
Yeah, and it's starting to rain pretty good over here.
Yeah. I guess we needed it the last few days.
Ooh, it was really hot.
Yeah.
Humid. It's like Florida.
For sure. Well, it looks like there's a little break in the doorbell. So Matt, why don't we get started with our introduction of the birthday boy?
Sure. So yeah, first of all, happy birthday to Dr. Gerard Baltazar. Happy birthday. He is class of 1998, and we welcome here today to our second virtual Tower Talk. Dr. Baltazar, he graduated Tower Hill, like I said, in 98. He then went on to Georgetown University, graduated from there, and went to Touro College in California, where he received his medical degree. Right now, he is an intensive care surgeon in the New York area, working for, I believe, at least 2 different hospitals there. And more recently, he's performed medical research for the critical ill as it relates to the COVID outbreak that we've been having. Gerard reached out to us and said he would like to speak, and we're welcome to have him. He's a very busy individual, father, husband, and he shared with Melissa and I how he's worked at times 36 hours straight on a particular shift. So we want to thank him today for being with us and sharing his view of kind of things that have been happening with his work. So without any further ado, I welcome Dr. Baltazar.
Thank you so much. Let me get my screen up. And there it is. Is that coming through okay?
Yep.
Thank you so much, everybody. Thank you to Tower Hill School, to the alumni group, Matt Twyman, Melissa Pizarro, Amy Wolf, all your help getting this going, and all your work trying to connect alumni to each other and to the Tower Hill family at large. I really appreciate that. As this was all happening, the COVID-19 right here in my cities, in New York, the center of this all, I struggled to figure out what to do with these experiences besides the clinical things, how to get out a message that I felt would be useful. And this is what the product is. It's still in evolution, but I really think that it's so far gotten good positive reviews, and I think we could get some good education out of it. I have nothing to disclose. I don't know about how you guys have felt, but it's been 100 days, 101 days now, 11 hours, some 30 minutes, some several seconds since this all started back in the beginning of March. And we're still in the middle of this. While we're still in the middle of this, I'm seeing more and more negativity coming out of this. While I'm also seeing some positivity, there's also a lot of misunderstandings and misinformation. I figured put together a talk like you always do of things that might be evidence-based, things that are personal, unfortunately, we don't have a lot of evidence-based or a lot of science behind what's happening with COVID because it's so novel and interesting. And as I was thinking about giving a talk specifically for Tower Hill, I started to think about multi-benefactor, what that meant to me, what it still means to me. And I do want to point out that I did hang up right over here over my left shoulder. That's my actual practice jersey from when I was on the varsity soccer team circa 1997, 1998. And despite my wife resenting the fact that I wear a haggard shirt full of holes, it does mean a lot to me. And I think it's symbolic of how much the themes of multi-benefactor and making sure you do the best you can using all the different tools that you can find, it still permeates my practice today, and I think it should come through in some of the things I point out in this talk. This was a very difficult last 3 months, but experience is a brutal teacher, but it teaches a lot of very good lessons. The first one that I experienced was that change can come quickly, and it's often unexpected and can happen with terrific force. And in that case, it helps very much to be prepared. Like most people, my family and I in the January and February, even though we're quite medically oriented folks, we were feeling quite comfortable in the stability of our systems, of our roles in systems, that we could change it, that we could make differences, but things were going to hum along fairly evenly. We heard about the outbreaks, but there were many outbreaks that never really hit the United States or the world in a way that was as dramatic as this one. The last time this global pandemic occurred was 100 years ago. And actually, as I'm a DO and I'm an osteopathic physician, and in our profession, we talk a lot about that pandemic because the osteopathic research from that time showed that without a vaccine being present, without any antivirals existing at the time, treatments that osteopathic physicians provided actually saved some lives. But even knowing that that was part of my professional history, there was a certain amount of hubris that made me disbelieve or discount that the possibility of a pandemic this large could even occur. But then it hit, and it hit for us incredibly powerfully. Mary Shelley once wrote that that nothing is so painful to the human mind as a great and sudden change, and I can assure you that is true. On March 1st, my family was visiting down from Elkton, and my mom was very worried. Oh, the virus is going to be there. It's New York City. We're going to get it. And I poo-pooed that idea. I said, no way. You're being just paranoid. Don't worry. It's safe here. And then on March 2nd, the governor announced that the new epicenter of the Northeast was young Israel of New Rochelle, a synagogue I pass every single time I take my 4-year-old to McDonald's. That X is my house, and that green is the area that ended up being the first lockdown, if you will, during the early days. So you can imagine how all of a sudden everything for us changed. We didn't know, should we go to the grocery store? Should we be doing anything in our neighborhood? And the feelings were shock, horror, fear, frustration, confusion, and a lot of worry. But one thing my family had been working on to try to prepare us for anything going forward was to address our resilience and our vulnerability, which I think are two sides of the same coin, really. And what we found as this was starting to happen is that we need to check ourselves. We need to be prepared ourselves for what we needed for support and what we were able to do and how we could go forward the best way possible. This manifested itself as a rallying of our support structure, calling our families, calling our colleagues, creating chats with a bunch of people who might be going through the same thing, asking them, what are you seeing? What do you know? Contacting colleagues out in other countries to see if they could give us any advice. And I think that's a big part of this lesson of preparedness is you have to prepare yourself first. You have to be ready emotionally and intellectually to deal with the issues that challenge your resilience and be open to being vulnerable. Because vulnerable is not weakness. It is actually a great measure of courage. There was so much unknown, and I definitely use this phrase on a number of occasions that we're going to have to science the heck out of this. And what we did as a part of preparedness is we just started reading whatever scientific studies were coming out, and there were so few of them. We were watching television, I'm sure that most people were using the medical social media, which, by the way, is huge. Medical Twitter is a huge resource for us to communicate to each other and share ideas and to develop concepts of for research, for developing practice pattern strategies. We were preparing to adjust our roles. One of the things that was haunting my family is the moment we heard that this was here, right in our neighborhood, and it was going to explode in New York. I knew that I would eventually have to leave home and start facing this thing and leave my family. So we had to prepare for just those roles. My in-laws, who were our primary caregivers for when we were at work, they couldn't be around us because of their difficulties with my father-in-law with asthma. And because the changes were quite haunting, that there's not really truly a non-zero chance that I could die by being out there, and my wife might be end up called up as well to do some work. We spent a lot of time preparing our family with looking at make sure our end of life paperwork was in place, power of attorney. We checked make sure our insurance information was available to family members who might have to access it. We called our next of kin, the people who were supposed to take care of our children in case something happened to us, just to tell them, be ready. In case. I just want you to know that we're going to probably call on you for some support if this thing gets really bad. And overall, our goal in those early days was to just prepare for the front line because it was coming. Apparently there was little things on the slide. And it did come, and it came fast. Everything ramped up really, really fast. We ended up with the first patient coming to my hospital on March 6th, 4 days after this all began. So you can see how fast this is spreading. By the 12th, we've taken our kid out of school. My wife has lost one of her jobs, and she had to quit the other one to be there to take care of the kids. And I already had my go bag packed, ready to go the moment we got called. And my mom was going on Facebook and recruiting for PPE, which was quite a beautiful thing that I was impressed that she was able to accomplish. We started to execute various plans. There were meetings after meetings, phone calls after phone calls, trying to organize how this should be moving forward. And it was a bit discordant in the beginning, whether we're supposed to be wearing masks at work, which masks we're supposed to be wearing, if any. Some hospitals were wearing masks, some other hospitals weren't. The goal, despite this confusion that was starting to occur in the very beginning, was it was clear that it was to keep as many people alive as possible. And so we had to be accommodating for the rapid changes and be prepared that something could shift at a moment. And things did start to get very uncomfortable. But what made it comfortable was knowing that we could create a team and execute some optimal team dynamics to really get through this. And that's what I saw happening around me at my institution, was that we harnessed the hospital skills, the ingenuity of our staff, and a well-established structure, and the number of resources we had was phenomenal. We were able to do various things with that, like change the area that we would have entrances and exits. This on the right-hand side is actually a conference room. You can't tell now, but that was a conference room where we would hold our M&Ms and grand rounds, which in order to accommodate all the number of patients that we did receive, they took down all of those things, ran oxygen lines, suction lines, and created ICUs. Down here on the left, that's an outpatient center converted to an inpatient center, so that when patients were delivering their babies, we could have a place for them to go if they were positive. Then we also built these tents to accommodate the patients. We also built other tents to help staff have places where they could change their clothes outside, so that they would have some kind of distance between the COVID environment and the non-COVID environment. What was key during this, and is key in medicine in general, I think in every teamwork interaction, is leadership. Leadership was very communicative during this time period. They were sending emails, organized and focused in the morning. When I get up, I know what's coming for the day, where I need to shift some patients, where we might have some resource limitations. by the afternoon, there was another update. There was another update in the evening, and there are multiple sources providing these, from the outpatient section to the overall hospital and enterprise to just my division and my department. And one of the themes that came across was that this is a effort to spend money knowing that the income, because surgeries aren't happening, is going to be tremendously much lower. And so we knew we were going to be at a deficit, but it was repeated, and with good reason and good intent, that this was not an issue. That things might happen down the line, but right now we had to prepare and focus on making sure our team was okay. If we had had more time to prepare, I think everything would have been a bit different. And that's fine that we were taken all by a little bit of surprise. But again, it was this team dynamic that helped us prepare very well. We were able to build negative pressure into rooms all over the hospital. The education about super spreading events was very clear up front. Super spreading events being events where, such as intubation, CPR, operations, where aerosolization of the virus could infect anybody in that room. And even though you cannot communicate clearly nuances of many things, it was very clear that they're trying to at least communicate very clearly and have everyone be up to the par with education for these super spreading events. Which I think is an important thing to do. Is if you're going to get messaging out there, your messaging has to be about the most important or highest risk in this case. We were able to localize patients in particular units. We furloughed people who didn't have to be there to expose themselves, cohorted patients who had COVID in rooms, and we were focused on discharging people as soon as possible, both COVID and non-COVID, because we needed the beds, and there was still an unclear understanding of what the transmissibility of this disease was from patients who were, for example, down the hall in the same ICU as a COVID patient. We tried to avoid admission as possible, avoid admission if it was at all possible, because again of the resource limitations. And also, we started to find that there were ways to manage these patients in the outpatient setting if we were careful enough. It was a beautiful symphony of quality organization, which I hope it can be replicated in other areas around the country where this is starting to surge now, Arizona, Texas, and if there's another surge here. These figures on the right here, they're pretty telling. The arrow is pointing to the moment where we began to open up the final ICU areas that we could, which was the operating rooms. Converting the operating rooms into ICUs is, as you can imagine, it's bizarre. It's a bizarre idea. We don't have the same kind of ventilators. We can't do the same kind of medications in there, and the staff isn't maybe as trained to provide intensive care as a formal ICU. But that was occurring at this point well before the peak. So you can see how fast things were filling. One thing I appreciated immensely was the way the institution and people in general were dealing with the stressful moments, that they were opening their hearts to each other. Patients and families were very much under stress, especially when hospitals closed to visitors. I had several challenging conversations with family members who I understood were getting angry, getting frustrated and upset because they couldn't be there in person, because they had so much love for these people who were suddenly being taken from them. And if you understand that dynamic, it's easier to approach people who are very distressed by what's happening. The same thing was happening with the staff. We were not only taking care of ourselves, but we were trying to take care of our colleagues. I cried in the hallways with several different people who were just having a horrible time trying to deal with this. One of my nurse practitioners, we had both left our families by this point, and we were both missing our children so much, and we just ended up hugging each other and breaking down the hallway, because it's just really impossible to go through something this powerful without admitting that we're human beings and we have so many emotions that are part of our lives. And what the institution did do well for us was create a forum, anonymous or otherwise, where you could express yourself. They offered treatments, psychological and otherwise, to try to help people get the help that they needed. And then there was this whole concept, as you can see, of response to crisis. Emotional responses to crises have a whole science and practice behind them. It's important to acknowledge that this is ongoing. In particular for trauma, we saw in the trauma center never stopped. But what we saw was a drop in the number of cases, but we also saw an increase in some particular types of cases. Those cases being intimate partner violence, child abuse, because that's another reflection of these emotions that people are going through when faced with such a crisis. I know I'm dwelling on this slide a bit, but I think this is really an important part of, besides the logistics of making a hospital function in the middle of COVID, this I think is an important idea that spans not just the hospital, but everybody's lives. There were many challenges that came up. When you have an unknown situation, you have a lot of, you can't anticipate what's going to happen next. So you have to take it day by day, moment by moment. Again, medication shortages. In the morning, we knew, okay, we were running out of propofol, so you have to try to maybe consider switching to ketamine or some other sedative. And it was a lot. There was a lot of improvisation, a lot of attempts to work around our usual practices for the benefits of the patients and to deal with the shortages of medications and staff. We redeployed a lot of our staff who were not critically care trained or who were not really adept at taking care of pulmonary conditions. People would be reorganized into getting vascular access, because in order to stabilize a lot of these patients who had shock or needed dialysis or just needed very close hemodynamic monitoring, we need to have a whole team to do that, so the rest of us could focus on other things. We created proning teams that help turn patients, and these were the OR staff that weren't doing operations, some of the orthopods. We had to contend with staff and family getting sick. There were many staff members who got the virus and had to leave. We were taking care of some of our colleagues in the hospital. We had to raise up some of the staff qualifications, give people temporary critical care education, teach basic ventilator management in order to have some depth of staff to give people relief. And we brought in a lot of travelers from around the country, whom I'm very thankful for, who helped supplement our care. We had to figure out how to do with the non-COVID patients, as I've discussed briefly. And we had to figure out, as a surgeon, had to figure out what to do with the operative COVID patients. What are we supposed to wear in the operating room? Is there higher risk? Isn't there? None of these things were answered. And then, of course, the home care discharge issues, which have come to define some of the response to how we handle the situation here in New York. These communications from the state itself and from within the hospital were really helpful. Getting us hospitals, just something as simple as getting hospital census every night gave an opportunity for us to stay on the same page and be united as a front to fight this battle. The next lesson I really took from this, and this is probably my most important one, was that human nature really is fundamentally good. Even and especially when faced with a global plague, this was a horror show. It was so bad at times that those folks who were there during the HIV crisis, they were saying this is just like that but worse. So you can imagine what it was like to be in this kind of environment, and how when you've moved away from your family, or you're saying rooms and rooms of patients with dying from the same thing, you have no cure, no treatment. We know this is not the flu now. That there were so many deaths, and these deaths happen so fast. The patient comes in to the emergency room, they die on the way out of the ambulance. It's the thing that takes people so fast. We're doing extreme critical care, keeping people on ventilators far longer than we normally would have, giving medications and treatments that we reserve for the most extreme patients, and these are now happening every single day, multiple patients a day, to the point where even our dialysis capabilities were strained, and we were having to split dialysis machines between two patients, split day and night, split feeding machines between patients. And we all had a uncertain sense of safety. and we were all starting to get haggard. None of us were sleeping well. It became kind of an ongoing joke. Oh, did you sleep? Nope. Woke up at 2:30, 3 o'clock in the morning. Okay, let's get back to work. You can see what it kind of our faces started to look like. We all had a little bar of red across our nose, and our faces were always contorted from the wearing masks all day. So in this kind of environment, it's easy to become cynical, apathetic, to then switch into a kind of safe transactional mentality because you don't want to deal with all this extreme pain. And if you can imagine walking into a room that's full of beds, like this was back in 1918, full of beds, full of patients, all dying from the same thing, and just add to that the modern accoutrements of monitors, ventilators, dialysis machines, infusion pumps. Their memory is indelible in my mind that I'll never be able to get out, and nor do I, because of what it taught me about the fragility of our humanity and what we need to do to try to grow from that experience. And traumas, and we continue to see them, but they were almost all of them seem to be related to COVID. Someone would come down, fall down, break their hip, and you'd scan their chest just because you were worried, and the chest would look like something like this. So we ended up having to change a lot of our practice patterns to be ready in case anything that comes to the door at any time could potentially kill each of us. And this was not the flu. I think this was one of the biggest mismessages that was put out into the public. This was not the flu. And we're not, and the same for the medical community. When this arrived, our first thought was, why did no one tell us? Why did no one tell us that this is not a typical pneumonia? It's an atypical pneumonia that may not be treated the best way with the standard methods that we had been using for other pneumonias. The cytokine storm that occurred with this is unlike anything we've ever seen. There is some expectation that the inflammatory response for our body is going to be standardized. You know, you get a trigger, maybe most people will get sick, maybe the kidneys will start failing in 2 or 3 days. And occasionally you would have these patients who would crash tremendously fast, and there'd be multi-organ failure in hours. But this disease that you are seeing people crashing from and having multiple organ failure in a matter of hours constantly throughout the day. 108-degree fevers. Who has ever seen 108-degree fever? And what does that mean for the patients? We had no idea. And just, how do you deal with that? How do you deal with something you just have not seen before? And then we experienced we started to see these thrombotic complications, blood clot complications that became one of the hallmarks of disease, of COVID-19, and what ended up killing a lot of people was that these small blood clots started accumulating everywhere, and we started to thin everyone's blood. About probably halfway through this, we realized, oh wow, all these people should be using blood thinners. And then the fact that it was put out in the public as a disease of the old and sick was a bit frustrating too, because that's not what we were seeing up front. Yes, the people who did worse were old and sick, but that we had people as young as in their 30s or 20s, pediatric cases, people in their 30s on ventilators, on dialysis, pregnant patients. We recently discharged there's a big press conference about this, a pregnant woman, or formerly pregnant woman, who came in pregnant with terrible COVID, had an emergency C-section on a ventilator, stayed intubated, and had to go through critical care on multi-organ dysfunction for weeks before she finally got out. And on top of that, death, the specter of death certainly was everywhere. Immediately we started to lose people we knew about. I worked with this neurosurgeon when I was working in the Bronx, James Goodrich. He died he was one of the first to die. And for me, there were a couple events that I know I'm already starting to run out of time, but there's a couple of events that I think I want to teach about here. One of them was a patient had he assumed he had the virus, and before he sought medical help, he decided to walk in front of a train. And so he arrived to me, and I ended up having to operate on him in this emergency. And right before I went in there, I called my family and told them, this is my first patient I'm operating on as an emergency during the COVID crisis, and I don't know what's going to happen. I've got double my PPE, extra masks on masks, like as if that would do anything. And as my resident is putting the saw through his leg to try to finish the amputation, the blood splatters right here and right there underneath my mask, underneath my face shield, all over my neck and face. And you can imagine what the next several days were like, waiting to see if maybe I'm going to start showing symptoms. Every meal you take and you sniff it real good, make sure, okay, I can still smell my food, so I'm not going to die today. that was a really trying time. And then I started to get over it, but then about 7 days later, a really good friend of mine dies, and he is this salt of the earth, Dr. Ron Berrier. He was one of those people who you want to kind of grow into, if you could, when you get to his age in medicine. And I've been following him. I told him not to go to work when he's at the beginning of this. I told him to stay home, and he said, I'm going to go to work anyway. He got the virus, went home to convalesce, and when I heard he was taking a turn for the worse, I asked him to come to my hospital so I could take care of him because he lives nearby. He ended up a day and a half later going as an emergency to the neighboring hospital, and by then it was just too late. One thing, I don't know why, it's a bit of an aside, but it's a casual talk. So I wanted to say that one of the things that was really comforting at that time when he passed was I was able to be in touch with some of his care team, and they assured me that even though he was not there with family or with his colleagues or his friends, that they treated him like they were family too. And that's what we tried to do for all these patients is make sure that they didn't die alone. And to know that they treated him as if he didn't die alone was really powerful, even though these two experiences, particularly Ron's death, really tried to break me. At one point, I'm in my partner's office. She had just lost 2 people that week, and I was about 2 days off from losing Ron. And we were crying in her office together, just trying to let out the emotions. And she's more experienced with these kind of things than I am. And she said, one of the things that we're doing here is we're trying to have control over this situation. We're trying to, that's why our emotions are so intense. I thought about that for a while, and I started to let go of the control, because this was a global wide phenomenon. How are we supposed to do anything about it? How are we supposed to save our friends? We want to keep people alive, but how can we possibly do this? And the more we beat ourselves up over the idea of trying to have control, it closes our mind, I think, to some of the good things that are out there. And those good things, I think, are the most important things to think about. The dedication will definitely be everywhere, but dedication and hard work are also everywhere. You're able to see this better once you clear your mind, let go of the pain of trying to have control over the situation. These are bags that we had piled up everywhere of people's PPE. So you should see these piles everywhere, because there's so many people coming to work trying to help, putting themselves at risk. This is one of my residents who is helping cross-cover a whole array of different services because we were down people, and you can see how many pages he's carrying, trying to help support the team. People would feed us, we would feed each other, and those little acts of kindness were so beautiful. People would make potions. This was made one of the nursing director of my SICU, her daughter made this one. And it's not just the medical profession either. It's all the people who are essential workers going to the grocery store. My life then was when I moved out to a hotel, isolate in the hotel, go to work, go by the grocery store, grab a bite to eat, go back to the hotel and isolate some more. So in seeing the people at the grocery store is really so inspiring, because they were as much at risk as we were. There's kind of love everywhere. I know I'm about to go over 30 minutes, but I'll speed through here. I just want to dwell on this a bit. I was able to see better the things that people were doing out there, all this good that was coming out of people internationally. I don't know if you know these guys. They made a little song and dance competition for how to wash your hands for coronavirus. This image stood out for me so tremendously. In Brazil, they projected medical workers onto the Christ statue. The hotel workers were so appreciative and kind. There was no one ever acting scared that we were there, and despite the fact that we were wearing scrubs and masks. Random patients would just reach out and say, "Hey, I just want you to know I appreciate you." Just out of the blue. Folks were donating so many different things, safety glasses, masks, and especially in the climate that we're in right now. I want to tell this story. It's referencing this picture right here. I was speeding down I-95 going to work. There's nobody. It was really eerie for a while. Even for surgeon hours, there's nobody on the streets. So I was speeding down the highway, and a cop pulls me over. I said, "Yeah." I come to the window. I said, "Yeah, I was speeding. I totally admit it. There's just no one on the road." And he says, "Okay, I'll come right back." Goes to this mask, and he says, "I want you to have this because you need it more than I do." And I'm starting to tear up, "Oh my God, I thought you were gonna give me a ticket. What's going on?" And at first I say, "No, thank you, it's okay. We have supplies where we're at." And he insisted, I take it. And we have this moment where we just have this mutual understanding that we're both out there trying to do the same kind of good in our own way. It's just another example of things of how much, even though so much terrible stuff is happening, that there's so much great out there happening too. This is my boss, the chairman, who went on Good Morning America because he put out a video for us of him performing Rise Up. And again, just these little beautiful acts of kindness, they mean so much. I'm going to skip past here. This is just stuff about research that we've done. The research is fascinating. We've joined global groups collaborating to try and figure out what's the best way to approach people surgically at this time. How we've experimented with different ways of using ventilators. And as a part of multi-benefactor here, I want to show that as an osteopath, there are different techniques that you can use that are maybe considered complementary alternative medicine. And I think it's important that we don't draw too many boundaries over what's possible. You have a disease you've never treated before, and you have some treatments that might be a little esoteric, but maybe help the patients who are going through this. Osteopath manipulation is one of those things that actually was shown in papers in the past to make pandemics have better, people in pandemics have better survivability. I took some of my days off from my one job to go and help out at some of the poor hospitals. And this is an important point that I want to make. In New York City, having worked in many underserved hospitals, it's very clear, it's kind of an open secret that if you're in an underserved community that's of color, that has more immigrants, that has less people education, and has less insurance, the hospitals are just not going to have enough resources. And folks are going on TV and saying, oh, no, these doctors are just making it up. There aren't many people straining. My hospital was strained. We were challenged, but we were never at a deficit where we felt we were going to collapse. But there were many hospitals that were, and it's these underserved or under-resourced hospitals. They did not have adequate hemodynamic monitoring. They did not have negative pressure, which really helps protect healthcare workers. When you don't have negative pressure, it's just the virus just hanging out and the air becomes full. Dialysis, I think, is something that is really necessary. Patients with COVID, they descend into multi-organ failure, need dialysis. At the same time, they're in shock. And without particular dialysis machines, which are not necessarily required, but are really important for critical care, in some centers, getting renal failure was a death sentence, and it shouldn't be. Not in this day and age, not with as much money as other hospitals have. ECMO, which is an external heart-lung machine, those machines need to be more pervasive. They need to have better ties to hospitals that don't have them in the hospitals. But at my hospital, we have it right away, and we were able to save so many lives just by putting patients on that, even though it was a challenge to keep them on those machines. Money became a big issue when trying to hire skilled workers. Travelers cost a lot more money than local nurses, for example. And there were two respiratory therapists contacted me during the middle of this saying, hey, we're being offered a lot of money to work elsewhere. Should we go? Do you know anybody at this hospital? It was a little bit heartbreaking to hear that was happening, but I understand. I do understand. And it's important that we recognize that these safety net hospitals are where the problems are really going to lie, not in the rich hospitals, but where there are good people trying to do their best despite the limitations. And these are some of my old crew back from my job in the Bronx. One thing you can take from this picture, which just came from a news report that called what they were going through a war zone. You look at all wearing different PPE. And that different PPE is reflective of the fact that they were relying not only on the essential supply, but on donations or even bringing stuff from home. So you can see this is not how it was at ours. We had very organized, or everyone's wearing pretty much the same thing. But here, this is the place where they needed the extra help. This is a device that my anesthesia colleague from an underserved community tried to build to try to accommodate for the lack of masks. This young man, he used his 3D printer to make a whole bunch of face shields to help supplement the underserved communities. Human beings, they really need to support each other through things like this. It is a true phenomenon that we are experiencing a lot of PTSD. This is a word cloud from a meeting with a psychologist that my department had for all of our physicians and nurses and staff. And you can see what we were feeling. This was about 3 weeks ago now. Everyone's feeling frustrated, drained, angry, guilty. This is real. This is a true experience that everyone in the country was probably feeling some form of. We have to really help each other out, even if it's a small thing like this, the proning team tying each other's gowns together. And I think knowledge needs to be shared a lot more than it has been. There are better organizations for research and better organizations for gathering latest knowledge. And a lot of people were asking me, because I work at NYU, one of the best places, and said, hey, what are you guys doing? And we would share our protocols, take it, do what you want with it. I'm not saying it's the right thing, but at least we can try. And the research folks, most of them were just not looking for credit. They were just looking to get information out there, what we were trying and how that made sense. The money issue, the fact that I think there must be better ways. My bottom line is there must be better ways to share our capabilities. Even in New York City, there must be better ways to allow things like dialysis machines to be used in places that really don't need them, so that we can help keep more people alive. And finally, not to take up too much more time, this is a catalytic time in our history. 100 years have passed since 1918, and we still talk about that pandemic and what it did for our communities, for our culture, for how we practice medicine. And 100 years from now, they're going to be looking back at this and saying the same thing. How did they deal with it? How did they face this tragedy? And I encourage everyone who's out there to take some steps to learn from our experience here in New York, get as organized and prepared as possible, and make sure to take care of yourself first. Make sure you're right with your amount of resilience and your vulnerability, so you can go out there and appreciate the goodness in others and to create goodness as often as possible, even in the face of tragedy, death, suffering. And please, I know it's a risk. Some of my colleagues were afraid to go back into the hospital, and many of them did not. But it is a risk. It's important that you do get out there and do what you can. There is some level of safety that we can do with a PPE, but even still, especially now that the numbers have dropped here in many parts of the country, there's so many things you can do to get out there and support. And if you do decide to donate, please focus your donations on the underserved communities, the healthcare systems that are struggling. The hospitals like mine, we struggled, we had our issues, but we were not nearly as suffering as much as the underserved communities of color, communities with immigrants, communities with lower socioeconomic statuses. They're the ones where the money needs to go. And I don't care what you believe, frankly. I just want you to stand up for what you believe is right. There's no better time than this uncertain present to help mold a better future. This is a new world. I wish we could go back to how things were before. I wish my kids didn't have to grow up being afraid of a virus that changed their entire lives. My daughter was playing outside, her ball blew over to the neighbor's yard recently. The neighbor kid picked my
Just like that.
Matt?
Yep, I'm here.
Here? Okay. I wasn't sure if it was me or on Gerard's side. Oh, there we go. He's back. Gerard, we lost you for maybe like 30 seconds there. Your screen froze a little bit.
Where was I?
You're telling the story of your daughter and the ball that went to the other yard.
Oh yeah, well, she was scared, and that's what she's learning from some of this, and I wanted to learn and I think we should all be thinking about what that generation is going to think of us, and how we're going to teach them to take the experiences that we've had and the knowledge that we've gained and make a better world with it. Because it is a new world, and that new world is an opportunity to make it a better one.
Awesome.
Thank you very much.
Thank you.
So if you have some time, Dr. Baltazar, would you be willing to take some questions from the group?
Absolutely. I don't have to do it except celebrate my birthday.
Which you have to make time to do.
Yeah. Put this back up.
Yeah, sure.
Go ahead. I'm open to anything.
So folks can either, there we go. So if we get back to the group view, let me see if I can do that. If you unshare your screen and we get back, so folks either, someone else just entered the waiting room. Either feel free to ask your question outright, or if you would rather type it into the chat box should be active. And I'm happy to read the questions for you. So whatever you prefer.
I'm open to anything. I like this. Last night I was giving a similar talk, and it was for credit, people were paying to be there. So it was a lot more formal, regimented, organized. So this is a lot more fun. Awesome. Thank you for that.
Of course. Who wants to be first?
Yeah.
Don't be shy.
Can you hear me?
Yes, sir, I can.
Gerald, congratulations. That was a fabulous talk.
Thank you.
I'm a retired physician who graduated from Tower Hill in 1960. And I've been sequestered up in the mountains here in North Carolina for the last 3 or 4 months with family. You spell things out so dramatically. Looking forward, what do you see as far as the public health service setting up a program that can respond a little more efficiently and a little more rapidly than we've done in the past 4 months? That is, you did a fabulous job of learning on the run, but there were no set plans for a pandemic or a epidemic of any sort. That's one question. And then the other suggestion is for those non-medical folks. Our book club, believe it or not, had just started to read Albert Camus' The Plague. And if you go back and read The Plague, it spells out everything that you've been through from a personal standpoint and for the feelings of patients and doctors toward patients and so forth.
Wow, I have to pick that up if I want to read it. To address your first question, thank you for the questions. They're really great. The first part of that, the pandemic response, absent federal response, absence of the CDC having a very strong voice, the WHO having a very strong voice in our country, we are doing this basically state by state. Thankfully, the Northeast has a group of states working together to try and keep the same standard. And in that way, we are able to do better contact tracing, better diagnostics, and better use of our inpatient and outpatient facilities. I don't know if that's the case elsewhere. I've been in touch with some of my colleagues in Texas and in Arizona, where they're starting to show signs of imminent surge now, and they are, some of them are telling me that they don't really get a sense that there's an organized approach to this. There's not an organized testing or contact tracing that's occurring if they can see, and some of them are in the medical field. I don't know what the best way to approach this is. A lot of folks talk about Sweden. You follow Sweden's data now showing that they had a higher mortality rate, but their economy is still struggling. I don't know what the right response is, but I do think we need to make more effort to take care of each other and be aware that we are not separate from our fellow human beings. If there was the movie and the graphic novel Watchmen keeps coming to mind to me, where at the brink of nuclear war, an alien comes down, so it destroys New York, and that alien was brought. That alien destroying New York brought people together, because there was this non-human force which was bigger than all of us that helped us realize that we are all one species and vulnerable to the same thing: rich, poor, politically active, not politically active, educated, not educated. We're all really victims of the same kind of non-human entity, and that's exactly what's happening now. And I hope that's the message that I'm starting to that's spreading around the world, is that we are one society in many ways. And if we try to focus on that, I think a lot of the rationale for how we're going to approach this from a medical standpoint is going to come out in simple ways, like wearing a mask. Thanks for that question.
Hey, I'm Larry Sullivan, 88. Thank you very much for the talk today. It was fantastic, really, really informative. I guess I have so many questions, but I guess the main one for me is that, would you say that when this whole thing started, we were all effectively operating in a vacuum, and we're all doing what they were telling us to do, and everybody was scared, and we all ran to our corners. Everybody kind of, and while we were running to our corners, we all hoarded all the resources that we could possibly get our hands on for fear that we'd be out of them. And,
Yeah.
And well, number one, just to comment that was dissimilar to other situations that I'd experienced, like 9/11, for instance, where everybody ran to the towers. This one, everybody ran away from everything. At least it seemed like that to us. And I guess the concern is, when I go to watch the news or to research things to figure out what are the best practices for me and for my family to continue to do, it seems like depending on what channel I'm watching, all the news is different, and the suggestions are different, and the rules change day to day, and people have agendas, and or at least it seems that way. From the medical side of it, I mean, I presume that your agenda is, assist everybody equally, and use everything that you have, all the resources that you have, that you can bring to bear on a situation. Would you say that you all have improved the level of care? Like if somebody gets COVID today versus if they get COVID, 2 months ago, are their chances better than they were 2 months ago? Or do we, and again, I mean, I don't want to make it sound like you haven't learned anything, but how much have we learned? And do people feel confident now that, we can start to get back to our ordinary lives, or should we all just stay in our cocoons until somebody figures something out?
Wow, those are very good questions. Let me address the first one about resource hoarding. That's true. There was a lot of that reaction. But on the front line, what we saw was thousands of people coming from across the country, coming to New York, putting themselves at risk, volunteering in some cases to help. So there were, as the now famous quote from Mr. Rogers, there were all these people going to the fire, running to it. And I count myself as one of the people in that group, just so my chosen profession as an emergency surgeon, as a trauma surgeon. That's what we do. But there are thousands and thousands and thousands of people who did that as well. And
I didn't mean to suggest that the frontline workers weren't.
No, I'm saying it's human beings.
I heard about people that were denying, like co-op boards in New York, for instance, not allowing doctors that would come from out of town to stay there for fear that they would infect the other residents. I mean, that was kind of, not everybody's out for themselves, but we're all so afraid that nobody wanted to mix with anybody.
Yeah, there's a lot of fear, and unfortunately we do not know as much as we want to know. We do not know how to treat this. We don't have an effective vaccine. We don't have an effective antiviral. We are still going to rely on some of the principles of support and critical care management to get patients through this. One of the things were starting to slow down. Really, it started to slow down. We were starting to clear out some of the ICU rooms, and then I had a patient that I had to admit who was an older man who fell down the stairs and broke a bunch of ribs, and the ribs alone would have been enough to keep him in the hospital, and he might have ended up on a ventilator, but he also had COVID. And as his case was unfolding, it was shocking that it was just like all the cases we saw in the very beginning. And we could do nothing as little as we could for him as we could earlier. We had convalescent plasma, we gave it. We had remdesivir, we gave it. We tried everything, and he still died. And so we are still, and that was happening as the curve was starting to come down. So it was a reminder that we are still not well prepared to face this. Should we come out of our cocoons? I don't know what the right answer is. I think we have to face life. And my wife has been really cocooned herself. Besides going out with me occasionally to go for a drive, she hasn't left the house in 3 months. And so but we have to start going back into life. We have to change the way we approach life, wear masks, keep social distance until it's some other change. There will be a second peak. We don't know what that's going to look like. It's going to happen. It always happens. And maybe it's going to be small and meaningless. Maybe it'll be worse than this one, as the 1918 pandemic showed the variability per city in the second wave. However, knowing that, we can better prepare for the next one. And I think that's one of the reasons I go out and give these talks, is so that we can have, in the din of conflicting messages, at least this is a fact of what actually happened, at least for me, and what I learned from it. I know other people are learning from this as well, from the front line. And hopefully that message permeates in a way that's more authentic than the things that you get on the news.
Thank you.
So that actually, you just addressed one of the questions that we had that came through in the private chat, which was your feelings on a possible resurgence, and, you know, are there cycles? Do you find that there are cycles in this kind of thing? And,
Yeah.
you know, do you have any personal opinion on that?
Yes, there are definitely cycles. This is a well-known phenomenon with pandemics, but we just don't know what the characteristic of that's going to be like. And those rooms that I showed you that we converted from conference rooms into ICUs are empty, but they're still ICUs. We're not converting those back into conference rooms until there's some kind of period at the end of this. But right now it's just a very scary ellipse.
Thank you for that.
Ellipsis.
Oh, yeah. And we do have another one saying, if you're willing to share if you have had the antibody test, as other hospital workers that this person knows had never had symptoms but did test positive for the antibodies.
I did. There was a time where I was convinced myself through a wonderful internal protective fantasy that I had gotten it and that I was going to be fine, that I had all these antibodies. I have no antibodies. My family has not been exposed. My in-laws actually started coming back into the town this weekend, and we tested them as well. They haven't been exposed. So unfortunately, there's no idea. We have no idea how we would react to this. So the danger still is present. We are required to take tests now as a part of practicing.
And I have one other question here. Do you have a sense of why the messaging is so low on how dangerous the virus is or can be? And are you willing to share your experience on a broader scale?
It's just look at the way the world is trying to reopen, in my opinion, far too fast. Is that everyone wants to go back, and we like having that security that I started off this talk with. We want to know that we're safe. We want to know that our systems are safe, that we can have some kind of control. And that's what positive messaging is about. Saying everything's fine, or we'll be fine. It's only, you'll get through this. It's not a big deal. I think the media is underrepresenting how dangerous this disease is, and how rapidly and really violently it kills people when it is ready to do that. We haven't been talking about it much because we can't, it's HIPAA violations and that sort of thing. We can't go out and say, oh, did you not see Mr. Jones, who we had to cut off his arms and then we had to cut off his legs, and now he's still here with us, but he's barely alive. Kind of situations. We can't talk about those things too much publicly for one, because it's damaging for us to be, have to relive some of those things, but also because we have to respect other people's privacy. And I wish there was more out there just how bad this is. And with this new stuff that's coming out with the kids, it's really every time that something new comes out about this virus, it's very scary. And I hope folks can get that to try to process that fear in an intelligent way.
Have you seen any round trippers, like people that have been released and then come back? Can you get just like the chicken pox?
I don't know about reinfection rates. That's still unclear if that even occurs once you've made antibodies. But what we did see, unfortunately, a lot of was patients who looked fine after being in the hospital for a few days, and then they go home, and the cytokine surge happens for them, and they're found dead at home, or they come in as a fall. Like this gentleman who had a fall down the stairs. He had been treated as an outpatient for a long time until this happened, and then it just overwhelmed him. And there was a time when we were seeing a lot of bounce back of people we sent out thinking they were just fine, and then they come back and they're crashing. It's so unpredictable at this point.
So I have another question here from Meredith. Hi, and thank you so much for taking the time to speak with us today. This has been great. Do you worry that we aren't having enough of a discussion about wellness and prevention actions that we can take as we return to a more active society? Things such as moderate exercise, good sleep, etc., are so impactful to immune health and are being left out of the discussion on public health.
Yeah, I think we should definitely have more. We should bring to bear everything we can for this disease. It is unlike anything that we face as a medical community in 100 years. So yeah, I don't think there's enough out there about what we can do for wellness, what we can do for trying to prepare our bodies to face this. With the caveat, I said that with the caveat that even incredibly healthy people I've seen be taken down by this. You know, from what was it, Nick Cordero, the dancer, the performer. He's in tip-top shape. He's 40-something. He's young, and he got taken out by this almost. It's getting yourself as well prepared physically, emotionally, mentally is important right now, and we need to make that more of a lesson in regular life as much as in COVID life.
I actually have a couple questions related to this one. What are your thoughts about students returning to school in the fall?
I don't know. I don't know. I have no. I don't know. I mean, we've asked, my wife and I asked that question about our kid too. Like, are we going to put her back in school? What's going to happen? Right now, she's scheduled to go back, and so we're just taking it day by day. There was a point where we're taking hour by hour, and now we're doing about day by day. Hopefully, we'll be spreading that out by week, and then maybe we'll have a better understanding by August, September that there's some safety and security that we can have in schools. I would be really stretching my abilities and knowledge to say that I know one way or the other what school's going to be like in the fall.
Well, I guess from a medical standpoint, do you know, how long do you think that this kind of thing should last? From a medical perspective.
Well, historically, about a year and a half. My first impression was that by after the holidays, things should start getting back to much more normal, but we don't know. This virus, thankfully, appears at this moment to mutate slowly, and if it mutates slowly, then it gives us an opportunity to create a vaccine and to be able to build a herd immunity if such a thing is possible on a short scale.
So I have two more questions, it looks like, and then I want to be respectful of your time too, Dr. Baltazar. So if you have a hard stop at any certain time.
No.
Okay. So I have one here from Erica. Am I still coming through okay? Okay. I wasn't sure. I was a little glitchy there. Thank you for a great talk and all your hard work. Going back to what may have been learned over the past 3 months, have ICU docs learned some things like prone positioning and certain drugs that can help? And can you comment on that?
Yes, we definitely have developed better ways to provide critical care management for COVID patients. Proning is something we did right up front, and my group, we were trying to, when you're moving these patients that are critically ill with COVID around, they tend to be incredibly sensitive to even the slightest touch. Wow. They would desaturate all of a sudden. Their blood pressure would drop because they were that inflamed, and their lungs were that sick. So we ended up proning patients for hours on end, more than we would normally do, because every time we flip them, they become incredibly unstable, and some of them arrest. So proning techniques we had to adjust, and we learned how to do that as well as we could. My team did a experiment we changed our practice pattern to use something called APRV as a ventilation strategy, which seemed to help because we were able to turn down the number of sedatives and analgesics and other medications to support blood pressure when we use this mode of ventilation as opposed to more standard modes. So some of those data are going to come trickling out of various centers so we can conglomerate more accumulate and more knowledge and use that in the future. I don't know about medicines. The medicines we've tried, and we've tried them all. For the sick inpatients and the critically ill patients, nothing seems to be very effective. One of our physician assistants, I took care of him from the beginning to the end, and he had all of the things that were out there. Some of the things that are experimental, remdesivir, all of it, and it didn't do much, unfortunately. So there must be hopefully there's something else that we'll discover that will allow us to treat people better. But right now, really, we're leaning still on basic, well-organized critical care management, like supportive care.
Thank you. Let me see which one I have not gotten to yet. Would you recommend someone who does not have symptoms to have the antibody test or be tested for COVID?
Once it's much more widely available and easier access, sure. I think everyone would get some sense of understanding of their world better if they knew whether they had it or not. The only hampering of getting good testing is the availability.
Mm-hmm.
That's really it. I think everyone should get tested if we have the capability.
And finally, one more question that if you're comfortable addressing, and I think you've touched on it, what are you doing with your own children? Are you still kind of bubbling them up?
My wife is trying to. I'm trying to gently nudge them in the direction of going back into the outside world. My 4-year-old especially, she realized something terrible was happening, and she knows, and she sees the news report. She watches Cuomo every day with my wife, and so she's scared. But I want her to be able to, like I'm trying to with these talks, process that, help her process that fear, and so she can do something good with what's underlying that fear, which is knowledge that she is fragile and the world is fragile and our systems are fragile. So I'm trying to teach her that, while also trying to nudge her away from from the house into the real world again.
Thank you so much. This was wonderful.
Yeah, thank you.
Thank you, Gerard.
Thank you so much for addressing us today. And Matt, I'll turn it back over to you.
No, again, I just want to thank you very much for presenting today and taking the time. Like I said, I know you're quite busy. I thought your talk today was very informative, and I think helped everyone that was able to participate. So thank you. Thank everyone for coming today. Please be safe as we kind of move forward, and keep an eye out. We will be having future Tower Talks coming out. I think our next one is going to be on the 17th. But again, thank you, and thank everyone for attending.
And thank you all for your wonderful questions.
Yes, thank you so much.
Thank you.
Honor and privilege.
And happy birthday.
Thank you very much. Have a wonderful day, everyone.
Great.
You too.
Take care.